This is A&P Live Studio. I am your host. I teach A&P as a registered nurse and anatomy and physiology instructor for advanced healthcare professionals. As an instructor, I help professionals like you connect textbook knowledge to real-world clinical challenges. Today, we're stepping into the ER to conduct a clinical investigation into one of the most urgent emergencies in neurology, bacterial meningitis.
So, let's set the scene. It's 2 a.m. in the emergency department. Our patient is Pamela, a 21-year-old college student, brought in after her roommate called 911. She has a sudden, really severe headache, a high fever, and profound neck stiffness. Her roommate says she was confused, which is what prompted the call. Now, this classic triad of symptoms immediately raises a huge red flag for a central nervous system infection. And believe me, the clock is now ticking.
So here's how we're going to break this down. First, we'll look at the anatomy of an invasion to get the pathophysiology. Then, we'll decode the clinical picture, connecting the science to Pamela's symptoms. After that, we'll see how to confirm the diagnosis and launch a counteroffensive. And finally, we'll cover the aftermath and, importantly, prevention.
All right, let's start at the very beginning, the anatomy of this invasion. To really grasp what's happening to Pamela, we first have to understand the battlefield itself and how the enemy managed to breach the fortress that is our central nervous system. Okay, so the crime scene here is the meninges. Specifically, it's those inner two layers, the arachnoid and pia mater. These are really delicate membranes that wrap around the brain and spinal cord. They create this sealed-off area called the subarachnoid space, which is filled with cerebrospinal fluid, or CSF. Now, in a healthy person, this space is totally sterile. It's an immunologically privileged site, and keeping it that way is absolutely essential for the brain to function normally.
So how on earth do bacteria get in there? Well, the most common way is through hematogenous spread. A pathogen, say, colonizes the nasopharynx, the back of the nose and throat, then it finds a way into the bloodstream. From there, it faces its biggest obstacle, the blood-brain barrier. And these bacteria have evolved some pretty sneaky strategies to get across. Streptococcus pneumonia, for example, basically hijacks molecules, using its own surface proteins to latch onto receptors on the barrier's endothelial cells. Others use what we call a Trojan horse mechanism, hiding inside infected immune cells that then carry them across the border.
And once they're in, this image shows you exactly what happens next. The bacteria are now inside the sterile CSF, and they start releasing components from their cell walls. We call these pathogen-associated molecular patterns, or PAMPs. You can think of them like the enemy's uniform. They're a dead giveaway. They act as a red flag for the brain's resident immune cells, and what they trigger is a massive, and I mean dangerously uncontrolled, inflammatory response.
Let's break that cascade down step by step. First is recognition. Resident macrophages spot those bacterial PAMPs using their toll-like receptors. This recognition triggers a full-blown cytokine storm. We're talking TNF-alpha and interleukin-1 beta. These chemicals are like a siren, recruiting a huge army of neutrophils into the CSF. This intense inflammation then makes the blood-brain barrier even more permeable, more leaky, which causes vasogenic edema. And finally, those recruited neutrophils, in their frantic effort to kill the bacteria, release all these cytotoxic oxidants and enzymes. It's like friendly fire, causing massive collateral damage to the surrounding neurons. And this is the key takeaway. The host's own immune response is what becomes the primary driver of the brain injury. Okay, so now let's connect all that microscopic chaos back to our patient, Pamela. How does this inflammatory cascade in her CSF create the very symptoms that brought her to the ER?
Pamela's high fever, that's a direct result of that cytokine storm we just talked about. TNF-alpha and IL-1 beta get into the bloodstream, travel to the hypothalamus, the brain's thermostat, and they basically reset the body's core temperature to a higher setting. It's the body's systemic attempt to fight off the infection.
And her severe headache, it's really a two-part problem. First, you've got direct inflammation of the meninges, which are loaded with pain-sensitive nerves, but the second, and much more dangerous part, is the rise in intracranial pressure, or ICP. As those blood vessels become leaky and cause cerebral edema, the brain physically swells inside the rigid confines of the skull. This elevated pressure is also what's causing her confusion and altered mental status.
And finally, that profound neck stiffness, what we call nuchal rigidity. This isn't just a sore muscle. The inflammation travels down the meninges that surround the spinal cord. So when you try to flex the neck forward, it stretches those irritated, inflamed membranes. This triggers a protective, totally involuntary reflex contraction of the neck extensor muscles. It's that resistance to passive flexion that is a hallmark sign of meningeal irritation.
The clinical picture is pointing very strongly to bacterial meningitis, but we need definitive proof.
So this brings us to the next phase of our investigation, using the investigator's toolkit.
The absolute cornerstone for diagnosis is the lumbar puncture, or LP. This lets us get a direct sample of the CSF for analysis. It is so important, though, to draw blood cultures before we start any antibiotics. This gives us another shot at identifying the organism. And there's a critical safety check. If the patient is showing signs of severely high intracranial pressure, we'll get a CT scan of the head before the LP. We have to rule out a mass or swelling that could cause the brain to herniate during the procedure.
And the CSF analysis tells the whole story. The opening pressure? It's going to be markedly elevated because of all that brain swelling. The white blood cell count? It's flooded with neutrophils, the body's first responders for bacterial infections. The glucose is low. Why? Because the bacteria are literally eating it to multiply. And the protein is high because the blood-brain barrier is so damaged it's just leaking protein from the bloodstream into the CSF. A positive gram stain is the smoking gun. It can give us a direct look at the culprit.
So with the diagnosis basically confirmed, there is absolutely no time to waste. We have to launch an immediate clinical counteroffensive. Every single hour of delay in treatment dramatically increases the risk of death and permanent disability.
We immediately start empiric antibiotics. That means we're treating for the most likely culprits before we know exactly which one it is. The standard of care is ceftriaxone, a broad-spectrum cephalosporin that's great at getting into the central nervous system, and we pair that with vancomycin. The vancomycin is crucial to cover for the possibility of drug-resistant strep pneumoniae. This cocktail is started right away, right after the blood cultures are drawn.
Now, for a clinical question for you, in which patient populations would we also add ampicillin to this regimen, and why would we do that? Well, the answer is in patients who are at risk for Listeria monocytogenes. That includes newborns, adults over 50, and anyone who is immunocompromised. Ceftriaxone just doesn't cover Listeria very well, so adding ampicillin is essential for these groups.
We also have to consider adding a corticosteroid, like dexamethasone, and this is a bit of a double-edged sword. The whole point is to blunt that intense inflammatory response that's causing all the neuronal damage. The evidence shows it can reduce the risk of hearing loss and other neurological problems, especially with S. pneumoniae meningitis. But the benefit is less clear for other bacteria, and the timing is absolutely critical. It has to be given just before or with the very first dose of antibiotics. If you give it any later, the inflammatory cascade is already too far gone for it to really help.
Now let's talk about the aftermath. Even when treatment is successful, this inflammatory battle can leave behind devastating consequences. And these affect not just the brain, but multiple organ systems throughout the body.
Neurologically, the inflammation can lead to seizures, it can trigger strokes by inflaming the cerebral blood vessels, or it can cause permanent hearing loss. On a systemic level, the infection can escalate to septic shock, which causes blood pressure to just plummet. This dangerously reduces blood flow to the brain, which is already injured. That same poor perfusion can cause the kidneys to fail, and widespread inflammation very often triggers serious electrolyte imbalances, like hyponatremia.
The long-term impact is really profound. About 1 in 5 survivors of bacterial meningitis is left with a permanent disability. This could be anything from hearing loss and seizures to severe cognitive impairment, which just underscores how critical rapid diagnosis and treatment really are.
But you know, the most powerful tool we have is actually prevention. The development of vaccines against the 3 most common historical causes of bacterial meningitis, Haemophilus influenzae type B, Streptococcus pneumoniae, and Neisseria meningitidis, has truly been one of the greatest public health victories of our time, drastically cutting the incidence of this devastating disease across the globe.
So, let's wrap up our clinical investigation. We started with Pamela's frighteningly acute presentation in the ER. We then traced the pathophysiology all the way from the initial breach of the blood-brain barrier to that destructive inflammatory cascade inside. We saw exactly how that microscopic chaos created her symptoms, and we followed the evidence-based path through diagnosis and life-saving treatment. And that leaves us with this final, critical question. The central paradox of bacterial meningitis is that the body's own protective immune response is what causes most of the injury to the brain. This presents a huge challenge. So how might future therapies be designed to modulate this friendly fire? How can we selectively target the harmful inflammation while still preserving the antimicrobial response we need to save patients like Pamela? This video is for educational purposes only and is not intended as medical advice, diagnosis, or a substitute for professional healthcare decisions. Stay pathocurious and see you next episode.